Okay. The second thing, the reason for doing this class, right? First of all, I'll come back to the exam, everything. The most important about all these, right? Like all the exam nowadays, I think a lot of people are getting positive, right? Right. Okay. So students are sending me messages, what to do, right? So what can I do, right? So my parent is positive, father is positive, mother is positive, right? Right. So they all want to have an idea. That's one reason, right? Okay. So I too became positive. I think everybody got positive in our home, right? So I too became positive, and fortunately, like vaccine worked. Maybe that's why I like, right? Okay. And actually, the most of the things what I am discussing here is basically what I gained from Dr. Amita Fernando, the consultant chest physician. Actually, when my mother was admitted, I was with him basically. So every day I saw his approach, like saw his like, I mean, the way he comes and decides about each and every patient, right? So actually, I learned, I mean, basically everything about COVID with him, basically. So thanks to him and thanks for their great service throughout. Right. Now, the second most important thing, it is important for exams, right? Maybe like it will come more and more in the questions, like you have to know it, and a lot of students are now practicing as pre-interns in the hotels as well, like intermediate care centers, like, so you should have some idea and you should know like what to do, when to do, how to do, like that's a second reason. Like the third reason is not only in the ERPM MCQs, even I don't know how many KDU students are here. So even if you have an SCQ on this COVID, I mean, it's no wonder, right? You should be able to answer in a KDU student, not for the ERPM people. They don't have it anyway, SCQ, no? Right. The next important thing is the students who are about to start the internship, right? About to start the internship. Like you should have a good idea about COVID because you will come across a lot of patients, like at least for another 1 month maybe, right? Because I think we are vaccinated more than 50% now, double doses, right? So I hope it will go down, right? It will go down, right? So that's the next important thing, right? Therefore doing so. Right, okay, fine. So before starting this, right, okay, so what I will cover is, I will cover everything about the virology, pathology, management, etc. for exam purpose, right? Everything for the life purposes, internship purposes, and the student who are writing the exams, like it can be the ERPM, university exams. I'm not going to do a separate session. This is a session for everybody, right? So the next batch, like I didn't meet you for some time, right? Those who are waiting the November, December exam, and this is going to be the session, guys, right? Okay. Can you, okay, can you pin myself, Sanjeev? Can you pin my, can you pin me? Yes. Am I pinned? I don't know. Okay. Fine. Is it okay now? Right? Is it okay? Question? YouTube's fine. Okay, just send me a message. Okay, fine. Okay. So this is the one we are going to discuss, right, for the exam purpose as well, right? This is the one we are going to discuss for the exam purpose. We are not going to do separately. I will do a question session for the exam batch. Okay. Next thing. Just a two announcements, right, before starting the class. The November, December batch, okay, November, December batch, right? Now we have got a message. No, it's going to be end of November or late November or early December exam. So I hope you are there right now, right? Right, okay, you are there with the, what do you say, prepared. I have to do the paper classes part 2, right? Okay, paper classes part 2, right? Guys, mute yourself. Okay, the paper classes part 2. I'm thinking somewhere between September 15th to 20th, somewhere around that, we'll start the paper class part 2. Before that, you revise everything, right? So that is the final thing. So get prepared, right? So paper class part 2, I think, right? Don't worry, because these days we are out of touch a little bit, but it's okay. Still more than 2.5 to 3 months, right? So I will do about 15 classes, only 8 paid, another 8 or 7 or 8 free classes. So get ready for September, around September 15, right? And the juniors, right, the theory session 3 will be starting tomorrow, cardio, respy, and nephro, right? So just make sure, right, don't miss that, right? If there is time, I will immediately restream the section-wise papers as well. So that one more thing, the exam batch and the others, juniors as well, it's not only for the exam batch, right? Look here, you have seen the merit list, right? You have seen the merit list. Around 120 have passed everything in the first attempt. Am I right? Right, everything in the first attempt, theory, viva. I mean, the first 15 were there in the class like you, right? Those were online classes, right? So all for 15 were there in the class, and out of the 25, I think only one student, around 16 or somewhere, is not there in the class. All the 25 were there. So I hope you will do the same, because you are having the advantage. The current batch, the last batch, I mean, that was the best ever batch I have come across, right? But having said that, they are a little bit unfortunate because we are going with a very large local batch from 1000 dots. The next batch you will be going with a small local batch, so you have more opportunities. So try to top the list like what your seniors have done. Okay. So when it comes to Viva and everything, again, as I said in the last intensive selection, right? We'll make the course more and more strict, right? You have to examine in front of us, right? So sometimes you will be scolded, but you will be scolded only there. You won't be scolded in the exam, right? So the course will become more and more strict. You have to examine, you have to present to us, right? So I had told you the last time itself, now I will be putting into that effect because of the very good results this time. Again, as I said, the second timers, those who have come to us, they can come to us. The new students, the charge is very high. It's going to be 3,000 per class if they have not come to me the first time, if you are repeated. Yeah, so that's the plan, guys. Okay. So the final papers, get ready, like get ready for the exam. So this is COVID-19. I will do a session on paper later, right? So make sure the cameras are on. If your cameras are not there, you'll be removed from the meeting, okay? So we'll start from the very basics, right? Look here, right? Fine. So we'll start from the virology per se, guys. Look here. So you are aware this, right, SARS-CoV-2 virus, right? It belongs to the coronaviruses, which was initially described in 1960. So it belongs to a viral family called Coronaviridae. These, if you look at this virus, these are enveloped single-stranded RNA viruses, right? So if you further go into that, right? If you further go into this Coronaviridae family, right? So it has a subfamily called Coronavirinae. So there it is having further genomes, right, genuses. So this belongs to the beta coronavirus group, right? Your SARS-CoV virus belongs to this beta coronavirus group. So it has some other viruses which also belong to the same genus. You may have heard a few years back, there was a talk about these MERS, right? We didn't talk about MERS much in this part of the world, right? Because it's mainly in the Middle East, right? Okay, so it belongs to the same group. It's right, shares some same characteristics to a certain extent as well, right? So if you look at the virus, right, it's a single-stranded, right, RNA virus. So in the, if you look at the membranes, there are some membrane proteins. There is an M protein, right? There is an E protein. There is a very important protein called spike protein, right? Spike glycoprotein, right? Okay, why it's important, I'll tell you, right? So if you look at the virus, I just want you to know two things, guys, right? So when how this virus infects a cell, right? Okay. So I told you these viruses are having a protein called spike protein in their membrane. Spike protein in their membrane. So what is happening is the spike protein in the SARS coronavirus, right, 2, it binds to a receptor called AS2 receptors. You may remember the word angiotensin converting enzyme, what we are discussing in the medicine. Guys, you don't have to write that. The PowerPoint and the slide is, already uploaded, right? Okay. So it belongs to the, right? Okay. So it joins a receptor called ACE2 receptor, right? ACE2 receptor. So when this SARS coronavirus 2 joins the ACE2 receptor, guys, right? Look here. there is something here called TMPRSS2, right? This also helps in the joining of this virus, right? In the join, right, okay, in the joining of this virus. So this is the one I told you, right? TMPRSS2, right? This also facilitate the viral entry, right? So the other important point is, you don't have to know much, right? Just remember the word ACE2, right? Okay. So other important thing is, look here, guys. So if you look at these ACE2 receptors, right? Angiotensin converting enzyme 2 receptors, these receptors are predominantly found, right? You may be aware in the lungs, there are cells called pneumocytes, yes or no, right? So this is predominantly expressed, right, by type 2 pneumocytes, right? Type 2 pneumocytes. They are predominantly expressed by type 2 pneumocytes, right? Type 2 pneumocytes, okay? Fine. Okay, guys, are there? Type 2 pneumocytes. So not only there, right? Not only there, right? Okay, look here. But also some upper respiratory tract epithelial cells, right? And there are some enterocytes, right? Okay, in the gut, right? Small intestine, they also express these receptors. So your virus can join, right? Can go and join these receptors via its spike protein. It is attaching to the receptors via its spike protein. Okay, now, so we had the SARS earlier also, no, coronavirus 1, right? We had a SARS coronavirus 1 earlier, but we didn't have this much of problem that time, right? Because one of the reason is, guys, look here, right? So if you look at the SARS coronavirus 2, right? The spike protein in the SARS coronavirus 2, it binds to the ACE2 receptors with a higher affinity. They bind well, right, compared to the previous coronavirus 1, right? So the affinity of this, right, receptor to the ACE receptor is high, right? So what they suggest is, this may be the reason for the greater transmission. This may be the reason for the greater transmission. Okay, guys? Are you okay? Fine. Okay. So once the virus enters the cell, like pneumocytes, like that, it enters the cells, within the target cell, the virus is replicating, right? The virus replicates itself. Okay. Fine. Clear, guys? Give me a second. Right. Okay. Now we talk about lot of variants now. Like we talk about lot of variants. You maybe heard about this alpha, right? Then you heard about this beta, right? Then we talked about this delta. Now we are talking about this mu, right? Has it come to Sri Lanka? I'm not sure. Right, mu, right? Okay, so right, so maybe almost all the letters are used. So if you look at this variant, what is a variant, right? So variant is a virus, right? Where the genetic sequence differs from the parent. Look here, guys. Like most other viruses, okay, like what we see in the other virus also, right? This virus evolves over time, right? With the times, the virus changes because there are mutations occurs in the virus, right? Most of the time, right? Okay, look here. Most of the mutations that occurs, right? It has no impact on the viral function. Clear? Right? Most of the mutations which occurs, right? It has nothing to do. They are not harmful. But there are certain variants, right? Like the variants which we have listed here. There are certain variants, right? So we are paying much attention to these variants because, right, they are rapidly emerging within a population, right? Okay, they are rapidly emerging within a population. That is one point, right? The second thing is, right, the transmission rate is high. right? The second thing is what? Just listen to me, guys, right? The transmission rate is high. The third thing is, so when there are mutation, when there is a new variant, it may not respond to the available treatment. For example, we are using some treatments which are monoclonal antibodies, right? We are using some treatments which are monoclonal antibodies. So these variants may not respond, right, as we predicted. The most important thing is, at one fine day, if the variant is not neutralized by your vaccines, right, it will cause a huge problem. Clear? That's why these variants are important. So each and every variant is not a problem. But having said that, right, there are some variants, right, okay, guys, which are causing the above problems. Are you okay? Right? Yes or no? Can I move on? Right? So these variants, like, tell somebody, guys, somebody keep it unmuted, right? Come on. Yes or no?
Yes, sir.
Okay, fine. So these variants which are causing these problems, right? These variants which are causing these problems are called variants of concern, right? Variants of concern, right? So when we talk about these variants of concern, so these are the main variants of concerns we are, right, talking about, right, talking most of the time, right? Okay. So if you look at the variants of concern, other than this original name, look here, right? Other than this original name, there is a nomenclature, right? There is a nomenclature used by the WHO as well, right? There is a nomenclature used by the WHO as well. Okay. So the WHO is using the nomenclature using the Greek alphabet, right? Right. WHO is using the nomenclature using the Greek alphabet. So one of the variant we talk is B117, which is called as alpha, right? Okay. It was initially found, the first detected in UK, right? So it was found to have 50% increased transmission, right? So there is a potentially increased severity, fatality, and hospitalization, right? But when it comes to the monoclonal antibody therapy response, it did not have a big problem. Okay, just have some idea, guys, right? Okay. So after this alpha, right, the second variant, right, which was directed in South Africa was the beta, right, which is B1351, right? So again, compared to the original virus, it has increased transmission. And very importantly, as I said, there is a significant impact on the treatment because, right, the monoclonal antibodies, right, it does not have the expected effect on this variant, right? Okay, we don't talk about the sera now, we don't have to bother about that. Then there was a variant by Gamma, which was detected in the Japan and Brazil. Then comes our Delta, okay, which was directed in India first, right? So compared to the alpha, the main problem what we face, what India faced, right, because this Delta has a very high increase in the transmission rate, right? It has an increased transmit, right? Okay, transmissibility, right? The second important thing is this Delta has a very potential increase in the severity. So that's why the hospitals were filled, right? Because there is an increased hospitalization, right? Okay. So there was a concern, right, whether there is a reduction in the vaccine effectiveness. You may be aware at the start, we were talking a lot about the vaccine effectiveness when it comes to Delta. But even though there is a reduction in the vaccine effectiveness, when it comes to the severe disease, right? When it comes to the severe disease, right? The vaccines were effective, right? The vaccine effectiveness was not an issue, when it comes to the severe disease. But a lot of people got it, right? Even though you are vaccinated, you get it. But the risk you are hospitalized, the risk of severe COVID pneumonia, the risk of death due to COVID pneumonia, right? It was, right, the vaccine was still protective, right, even against this Delta. Understood? Are you okay up to this? Come on, guys. Right, it's not for, I'm just, this is for the knowledge also, right? Fine, look here. Now the new one, right, was the epsilon one, right? Epsilon, right? Epsilon, right? Okay, epsilon. So again, there is an increased transmissibility, right? Okay, we don't know much about this. We have to wait for the data to, right, get more and more idea about this, right? And there was a significant impact, right, on treatment using monoclonal antibodies, right? Okay, clear? So that's about the virology. Are you okay, guys? Right? Right, I'll give you about 30 seconds, have a look. Let's see whether everything is okay. Is my speed and everything is okay? Yeah? No lagging?
Sir,
come on. Come on. Didn't you send me a message? Right, okay, good. Fine. Now we'll talk a few words, right, about the pathology and the pathogenesis, right? Okay. Right, okay, look here, guys. You don't have to bother too much, right? You don't have to bother too much. Just listen to me, right? So if you look at the changes that occurs in the lung, right, okay, due to COVID, there are a lot of things happening, guys, right? You know, there is a pneumonia. So there is a diffuse alveolar damage. That's why they are having hypoxia, right? It's not only the alveolar damage, but also they can bleed into the lungs. They can have alveolar hemorrhage. Not only the viral pneumonia, like look here, not only the viral pneumonia, but also they are prone to have the secondary bacterial pneumonia. Like they are prone to have the secondary bacterial infection. This is the place we are using antibiotics when we are suspecting this. Clear? The next important point is, guys, look here. The COVID, right, this coronavirus COVID is a thrombogenic condition, right? This disease is a, right, prothrombotic. You are having more risk of developing thrombus. It's a prothrombotic condition, right? The disease is a prothrombotic condition, right? So if you look at the thrombus, the predominant main thrombus they are having is microvascular thrombus, right? There is thrombus formation within the small vessels, right? Actually, in a few minutes, I am going to talk about, okay, stages of COVID infection. One of the important thing is, okay, right? One of the important thing is, fine, look here. If you look at this thrombus formation, right, or this prothrombotic condition, it is there in all the stages, right? Right, it is there in all the stages of the disease, right? This thrombus formation occurs not only in the lungs. In the lungs, you can have pulmonary embolism, right? In the lungs, you can have pulmonary embolism, right? Right, it's not only in the lung, right? But also in the heart. That's why you heard about MIs, right? MIs. Strokes in the brain, in the kidney, right? In the kidney, right? It can happen anywhere. Okay. Fine. Okay, look here, guys, right? So there were, in addition to that, there is aberrant vasodilation, endothelial dysfunction, right? So this is what lead to, right? This is what lead to pulmonary edema. right? Later, there is fibrin deposition, hyaline membrane formation, right? So there is a chronic risk of these people going into lung fibrosis. I will talk in a few minutes, right? There's a chronic risk. These people are developing lung fibrosis, right? Okay. Look here, guys. It's disastrous, guys. Actually, I also didn't everything when it comes to right? So until that we don't know, right? We also went everywhere, right? We didn't take it that seriously, right? When it comes to the problem, right? Now look here. So if you look at the biopsies, what is there in the lungs in the biopsy, right? There is a detachment of the type 2 pneumocytes, right? There is an intracapillary thrombus formation, fibrous deposition, there is an organizing pneumonia. Later, they are developing lung fibrosis, fibrosing, organizing pneumonia. Look here, guys. Okay. So if you look at the lung fibrosis that occurs in COVID, right, unlike the other diseases, what we have seen up to this point, right, the COVID lung fibrosis can occur early, right? COVID lung fibrosis can occur early. It can start early, even, right? It can start early, even such as day 14, right? Day 14, just 2 weeks, lung fibrosis can settle in, right? Actually, I remember this is the place, Dr. Amita Fernanda used to say us, this is the place, right? They are using sometimes steroids, right? Methylprednisolone to stop this lung fibrosis. Otherwise, this patient will go into lung fibrosis and he's going to have lung fibrosis in the long term. Clear? So if you look at the pathology what occurs in the lung, look here, guys, look here, look at me, right? Don't worry too much, but just have some idea, right? Initially, there is a stage called L type, right? There is a stage called L type. Look here, look at me, look at me, look at me. Is that L phenotype? It's there, everything is there in the tube, right? Tube has been already uploaded, right? Then there is a phenotype called H phenotype. Later, right, they can go into something called fibrotic, F, right? L, H, and F. L, H, and F. Right? Look here. I'll tell you what is this. Right? So what is there initially is the L phenotype. Right, L phenotype. So if you look at the initial phenotype, guys, look at me, look at me, look at me. Right? If you look at the L phenotype, here everything is low. Everything is low. Right? That's why the word L. Right? Your lung is like a liquid, in the liquid state. Lung is liquidified. Right? Liquidified. Right? So if you look at these people, right, okay, just listen, guys, okay? If you look at these people, they are breathing near normally. When you look at them, they are okay, right? They are breathing near normally. But if you check the saturation, they are having hypoxia, right? But right, the breathing looks normal, right? So you may have heard the word happy hypoxia, right? Right? So this is the happy hypoxia, right? So what is happening here is, right, these people are compensating by increased respiratory drive with the increased tidal volume, right? So their tidal volume is high, right? Their tidal volume is high, right? So normally we have about 500, no. So these people have tidal volume sometimes 800, 900 like that, right? Tidal volume. So elasticity is low, low elasticity. They are in loss of hypoxic pulmonary vasoconstriction, so which will lead to VQ mismatch. You may be aware in a normal lung, I have told you in the respiratory module, right? There is something called ventilation and perfusion, no? Right? So there is a match between ventilation and perfusion. So this ventilation and perfusion, here there is a mismatch, right? If you look at the CT scan, right? If you look at the CT scan, there is some, I will show you the films in a few minutes, right? There is something called ground glass appearance, right? The classic appearance we are having is called ground glass appearance. So if you look at this ground glass appearance, they are mainly in the peripheral areas, like close to the pleura. They are mainly in the peripheral areas. Mainly in the peripheries, they are having an appearance called ground glass appearance, subpleurally, right? And along the fissures, right? Okay. So do you have some idea about this L stage? Huh? Lung is liquid. There is liquid in the lung, right? They look okay because, right, they are increasing their tidal volume, right? They look happy, but they are hypoxic, right? Okay, this is what you call it, happy hypoxia, right? So elasticity is low. Elasticity of the lung is lost, right? So normally when there is a hypoxia, right? Let me look here. Normally when there is a hypoxia, well, look here, guys, right? It's like this, no? You may remember, this is the alveoli. This is the alveoli. This is the blood vessel. This is the blood vessel. So the deoxygenated blood will go. The CO2 will go here. Oxygen will go here. Yes or no? Right? CO2 will go into the alveoli. Oxygen will go into the blood. This is how the lungs is oxygenated normally. This is how the lungs is oxygenated. Yes or no? Right? So this is what we call as what? This is the ventilation. Right? This is the perfusion. Perfusion. This ventilation and perfusion is in a balance. Right? That's what we call VQ match. Ventilation, perfusion, balance. Right? Ventilation, perfusion, balance. Clear, guys? Right? Yes or no? Now, come on, look here. In a normal lung, look here, guys. Look here, look at me. In a normal lung, if there is a hypoxia here, right? In a normal lung, if there is a hypoxia here, if you send the blood to that alveoli, will that be oxygenated? If there is a hypoxia there, if you send the blood to that alveoli, will that be oxygenated? Yes or no? No. So how that is prevented? That vessel will constrict. When there is a hypoxia, this vessel will constrict to prevent the blood going to that alveoli. Yes or no? Right? Right? So when there is a hypoxia, there is a reflex vasoconstriction because your body knows there is a hypoxia here. If I send the blood here, it is not going to be oxygenated. Right? It is not going to be oxygenated. Right? So that's what you call as hypoxia causing reflex vasoconstriction. But what is happening here? That is not happening here. Right? That is not happening here. That is lost. Right? That is lost. Right? So they are having a ground glass appearance on the CT scans. Right? So what is the next stage? Come on, guys. What is the next stage? L stage and H, isn't it? H stage. Right? H. So what you are trying to do is you are trying to prevent these people going to the next stage. Right? Going to the next stage. Right? So that's why we are using dexamethasone. That's why we are using drugs like tocilizumab. Right? Because we want them, right? We prevent them going to the next stage. Okay. Right. Right. Okay. So if you look at the next stage, guys, look here. Right. That is called H type. H type. H type. Right. So here, if you look at the lung, right? If you look at the lung is solidified. It's like a solid, right? It's like a solid. Lung is solidified. So these people are having severe hypoxemia, right? These people are having severe hypoxemia, right? With a decrease in the lung compliance. So lung is becoming solid, no? So lungs weight is increased. Lung weight is increased, right? Okay. Fine. Okay. So there is inflammation, right? This inflammatory mediators is causing fluid leakage of the fluid. You call it pulmonary edema, interstitial edema, right? Okay. And there is atelectasis, right? So there is a condition here called SILI. What is this SILI? Is self-induced lung injury, right? Right. All this pathology leads to a right? self-inflicted, self-induced lung injury, right? It's a vicious cycle. It's a vicious cycle. Clear? So if I just have some idea, guys, like just have some idea. So if I tell about this L type, like the elasticity, the expansion, elasticity is low, elastance is low, ventilation perfusion ratio is low, recruitment of the new alveoli is low, lung weight is low, right? If you look at the H phenotype, right, high elastance, high ventilation perfusion ratio, high lung weight is like your ARDS. Clear? Okay, ARDS, right? So this is the initial stage, guys. Your lung is liquid. There are infiltrates in the lung, So we want to prevent this going to the next stage. That is the H-type lung. That is that there is a diffuse damage to your alveoli, right? The word is called silly, right? Self-induced lung injury, right? If it progresses, your lung will become fibrotic, right? That is your F stage, fibrotic stage, right? So there's a L type, H type, and F type. So these are the three types of lungs we come across in a COVID infection. Clear? Understood, guys? Yes or no? Right? I'll give you 30 seconds, just have a look. Right? Now it's very important to have an understanding. Clear? It's very important to have an understanding, right? So as I mentioned earlier, right, just the juniors who are here, remember, ERPM was not like the old days, right? As I told you several times, right? So I started the class 8 years back, like 24 years like you, right? So almost everybody in the class were older than me, right? About 40, 45, 50 were there in the class, right? So there you had a pass rate of medicine about 5%, 10%, right? So now we are having, I'm saying about we are having a 95% or even more than that pass rate. So this time Viva, maximum I have about 12 fail out of the 350 or 70 set for the exam, right? So the pass rate was high, right? Understanding is high, and more people are doing postgraduate, right? So if you want, I think in my last video, I told you about this internship and those things, right? In a sessions I did last week, right? So have a look on that, right? Have a look on that because it will give some idea, right? So now students want to score more and more marks. And again, that's the way it goes. Like there's no point in studying and becoming an MO OPD, guys. Like rather than that, better you be a housewife. That's better, right? So right now, most students want to do that. And so we are also bothered about that, right? We want to create more and more good doctors rather than ordinary doctors. Right. Fine, look here. Shall we move on? Okay, fine, look here. If you look at the stages of the disease, right? If you look at the stages of the disease. So the stage 1, right, some people are having a mild infection. If you look at the stage 2A, these are the people who are having a lung involvement is there. There is a pneumonia, but they don't have hypoxia. If you look at the stage 2B, right, which is called a moderate infection, there is a lung involvement with hypoxia. And the stage 3 COVID is there, systemic hyperinflation. That's a severe COVID, right? Okay, right. Now we'll go into the stages, right? Okay. So before going into the stages, okay, look here, guys, right? I'll just again tell you a few words, right? There is a pneumonia part, right? What is causing to the pneumonia is, right? Like the pathology, there is a ACE2 deficiency, right? Renin angiotensin imbalance. There is an inflammatory phase, right? What is happening in the inflammatory phase is there is a lot of cytokine production, right? There is a lot of cytokine production. The cytokines are overproduced, right? Right? So that is leading to systemic inflammation. I'll come back to that, right? That is leading to systemic inflammation, right? So you may have heard the word in COVID, there is something called cytokine storm, right? That is what occurs here, cytokine storm, right? So there is an acute lung injury, right? And when it comes to this prothrombotic phase, it is there throughout, right? Throughout the disease, the prothrombotic phase is there, right? they can develop coagulopathy, they can develop multi-organ failure, right? It is there throughout, right? Let me look here, right? Okay, look here. Fine. The first 5 days, right? The first 5 days, right? Okay, the first 5 days, right? After the infection, right? You can be asymptomatic, right? The first 5 days after the infection, right? You can be pre-symptomatic phase. First 5 days after the infection, you can be asymptomatic, right? Right, but you are carrying the virus. Clear? But you will become infective, right? Okay, you will become infective, right? You will become infective roughly about 2 days before the onset of symptoms, right? Roughly about 2 days before the onset of symptoms. There's another graph, I'll come back to that. Right, roughly about 2 days before the onset of symptoms, right? So if you look at the viral genome, it's proliferating to the maximum, right? And later it comes down. It comes down to very low level, roughly about 2 weeks, right? It comes down to very low level, roughly about 2 weeks. And you may be aware that is the reason for what? You may have heard about this isolation for 2 weeks, right? Isolation for 2 weeks, right? So if you look at the symptoms, guys, look here. If you look at the symptoms, I told you, right? Some people are having, right? Most of you might have had this infection by this time. Yes or no? Right? So, right, I have maybe I got about hundreds of messages. I am positive, right? Right, this positive for this COVID, right? So, right, if you look at these people who are having mild to moderate illness, okay, right? So their illness roughly lasts for about 10 days, right? Their illness roughly lasts for about 10 days. Clear? Lasts for about 10 days. But that is the people who are having about mild to moderate illness. So if you look at the other people, guys, look here. If you look at the other people, right? So their symptoms also start like this, right? Like your mild to moderate illness, their symptoms also start like this. So mild to moderate illness, what, day 6, day 7, your symptoms are settling, isn't it? Day 6, day 7, the symptoms are settling. Yes or no? Right? So if you look at the others who are going to have the severe infection, so their symptoms also start like this. But if you look at them, guys, they go into severe illness somewhere around day 6, day 7, day 8. Clear? Right? They will go into severe illness somewhere around day 6, day 7, day 8. Clear? So most of the people will come to hospital somewhere after day 6, day 6, day 7, day 8. That is the time they come to hospital with the pneumonia, right? So this about day 8, right? Day 8, they complain about shortness of breath. If the time is bad, right? So about day 9, day 10, they will go into acute respiratory distress syndrome, right? They will go into the ICUs, they will get bad around that time. Clear? Right? Those are the people who are getting bad. Right? Okay, look here, guys, look here. Again, it's a nice graph, guys, look here, right? Okay. So it's like this now, guys. Now we all know some people develop this disease and they come out without a problem, right? Some people develop the disease and they are the people who are going into what, right? Severe pneumonia and severe COVID, right? So that is nicely explained by this, right, graph. Look here. Now we look about a patient with a mild COVID infection. Are you okay? People, are you okay? Yes or no?
Yes, sir.
How many times I ask is okay? Yeah. Huh? I hope you're okay, right?
Yes, sir.
Yeah, I'm a little bit worried about you whether you're okay or not, because but when sometimes I listen to my restream, I'm thinking, okay, I'm asking this okay too many times. Right, okay. Right, look here. So if you look at this mild COVID, okay, if you look at this mild COVID, so if you look at this viremia, right, look here, viremia, the shedding of the virus, right, shedding of the virus, how long they can infect the others, right? So the infectiousness, right? So look here, this day 0 is the symptom onset, okay? Day 0 is the symptom onset. You got the infection roughly 5 days back, right? You got the infection roughly 5 days back. So it's basically the first 5 days you are asymptomatic, right? The incubation period is about 5 days. So, but you start infecting the others, right? You start infecting the others roughly about 2 days before the symptom onset, right? roughly about 2 days before the symptom onset. By the time your friend says, I'm not feeling well, it's done, right? Right? Okay, you got it right? Right? By the time your friend says, I'm not feeling well, you are already infected, right? Okay. So if you look at these mild illness people, their infectivity starts about 2 days before the symptom onset, and their infectivity ends early, guys, ends early, right? So it's about 8 days, they are becoming non-infectious, right? That's the reason beyond why nowadays we are in home quarantine. Earlier, we discharge these people early, right? Because by about day 8, they are becoming non-infectious, right? Okay. So if you look at their inflammation, they don't mount a big inflammation, they only have a mild inflammation. And everything, if you look at the inflammation, everything settles somewhere around 2 weeks. Day 14, 15, everything settles. Okay, right? Everything settles, right? Everything settles somewhere around 2 weeks, right? Look here. If you look at the viral direction, right? So your PCR, everything will become negative by about 14 days, right? So their infection settles about 14 days and they recover, right? This is the graph what we see in people who are going to develop the mild infection. On the other hand, guys, look here, right? On the other hand, if you look at the people who are having a severe COVID, right? Severe COVID, they also start to excrete the virus. They are infective 2 days before the symptom onset, right? Roughly about 2 days before the symptom onset. But their infective period is lasting for a long time, right? They are right. So if you look at the previous people, their infective period has come to an end about 7-8 days now, right? Okay. So here their infective period lasts for a long time, lasted for a long time. Okay, right? That's why we are keeping these people in the hospital for a long time, because they are more infective, right? So if you look at this, they are mounting a very severe inflammatory response. Clear? They are mounting a very severe inflammatory response. Somewhere around day 9, somewhere around day 10, right? Somewhere around day 9, somewhere around day 10, they are having a hyper-inflammatory response, right? This is the hyper-inflammatory response that is leading to complications. Okay, right? That is leading to complications. Okay. If you look at the virus detection, how long your PCR can become positive? Your PCR also can become positive even after 2 weeks. It can even sometimes go up to 3 months even, right? Your PCR also can become positive for a long time, right? Your PCR can be positive for a long time. Understood? Yes or no? Right? That's why we don't do a PCR on discharge, because no point, right? Right? We don't do a PCR on discharge because it can be positive. We know it can be positive. Are you okay? Right? So have you understood the difference between these two? Come on, guys. Yes or no? Right, look here, look here. Now, listen to me, right? I'll come to some important point. So the first 5 days are incubation period. Yes or no? Right? You are asymptomatic, pre-symptomatic, right? So then you are having the viremia. What is viremia? Virus in the blood, right? Then you are having the viremia, virus in the blood. Okay, look at me, guys. Look at me. Look at me. Right? This is the viremia phase, right? You are having fever, cough, diarrhea, headache, loss of sense, smell, taste, right? Some neurological problem, like skin problems, etc. Right? Okay, right? So these are the features of viremia, because this is very important to understand this, because now a lot of students ask me, sending me messages, sir, what about, have you heard about ivermectin? Right? Ivermectin, right? There's a drug called ivermectin, yes or no? Right? So can we use ivermectin? Right? So if you are using ivermectin, you have to use in this viremia phase, right? Viremia phase, viremia phase, right? Okay, viremia phase. Then because it is reducing the viremia. Then after that, right, some people will go into stage 2. Where they are having shortness of breath, hypoxia. Look at me, guys, right? Some people will go into stage 2, where they are having shortness of breath, hypoxia, right? Your saturation is less than 94%, right? Your saturation is less than 94%, right? Okay, right? Hypoxia. Are you okay? Right? Hypoxia, right? Hypoxia. Okay, now guys, look here. This is the time, listen to me, because these are questions you are sending me, guys. Like, I hope you won't be sending me questions anymore, right? This is the time when the saturation drops, when the saturation is less than 94%. This is the time we are using drugs like dexamethasone, steroids, right? Okay, this is the time we are using drugs like what? Come on, guys, tell. Dexamethasone, steroids, because some people will start to take dexamethasone from day 1 in the viremia case, but it's bad. So if you use dexamethasone from the day 1, right? If you use dexamethasone from day 1, what will happen is, guys, if you take the steroids in the viremic phase, it will prolong the viremia. Understood, right? Right, it will prolong the viremia. So these are the few risks about what? Self-medication, right? Right, self-medication, right? So without doctor's knowledge, or some doctors also prescribe like that, right? So we can't use steroids there. So this is the place we use the steroids. This is the place we are using drugs like tocilizumab, right? Right, anti-interleukin 6, right? So later, some people will develop the complications like ARDS, acute respiratory distress syndrome, SIRS, systemic inflammatory response syndrome. They can go into shock, and they can develop conditions like heart failure. And I told you there is a risk of thrombosis throughout, right? Right, coagulation problem, the risk of thrombosis is there throughout. Okay, right? Fine, look here, guys, right? So if you look at the people, right? Okay, listen to me, right? Who are having severe COVID, right? If you look at the people who are having what? Severe COVID. The problem with the severe COVID is there is a hyperimmune response, right? There is a hyperimmune response. Lot of cytokines are released. For example, interleukin 1, interleukin 2, interleukin 6, tumor necrosis factor alpha, right? Interferons. So this is leading to a state called cytokine storm, right? This is leading to cytokine storms, right? So that's why we are using these anti-inflammatory drugs, steroids, etc., to reduce the cytokine storms, right? So it can basically affect each and every system, right? Okay, kidneys, they can have oliguria, hematuria, right? Right, they can have hypoxemia, they can have eye problem, heart palpitation, heart attack, right? Myocarditis. In the brain, they can have headache, altered consciousness, right? Diarrhea, everything is possible, right? All these due to cytokines. Clear? Okay, fine. Are you okay, guys? Yes or no? Right. So the early phase, right? Stage 1, mild infection, right? So this occurs at the time of incubation, early disease, right? They have non-specific symptoms, malaise, cough, fever, etc., right? So either you are doing a PCR or you are doing a rapid antigen test, right? The treatment is mainly symptomatic treatment, right? Okay. Fine. So stage 2, I'll come back to this, right? So here there is a lung involvement, there is a pneumonia, there is an inflammation in the lung, right? So your chest X-ray is abnormal, there is bilateral infiltrates in the chest X-ray, If you do the CT scan, there is something called brown glass appearance, right? So full blood count, they have reduced lymphocytes, lymphopenia. Your AST, ALT is high. There is transaminitis, right? So there is something called procalcitonin that is typically normal, right? Okay, fine. So we are using steroids only when there is a hypoxia, right? The stage 3 is a severe inflammation, right? This is a cytokine storm I told you, right? So as I said, throughout the disease, there is a thrombotic tendency, right? That's why we are using enoxaparin, right? I will talk about it, right? Initially, we are using prophylactically. Sometimes we are increasing the doses, right? So the most common problem here is pulmonary embolism, right? There are microthrombus formation, microthrombi, right? They can have arterial thrombus, which can cause myocardial infarction, stroke, and they can have a condition called thrombotic microangiopathy, etc. Clear? Are you okay, guys? So if you look at the incubation period is about 5 to 6 days, 2 days before the onset of symptoms, you will start to transmit, right? So mainly, right, you will, right, okay. So mainly it's a aerosol spread. It's a droplet transmission, right? Especially the large droplets are traveling less than 1 micrometer, 1 meter, less than 1 meter, right? The large droplets, which is more than 5 micrometer, they travel less than 1 meter. So mainly the main form of right transmission is the droplet transmission. So if you look at this droplet transmission, guys, right, the chances of getting the infection 90% of the time is from the droplet transmission, right? Okay, droplet transmission. So the risk is high, right? The risk is high when you are within the 2 meters range, right? When you are within the 2 meters range, right? From an infected person, right? Right. So it's roughly about 6 feet, There was a concern about this airborne transmission, whether the small droplets can travel more, right? Even after the patient has left, can you have a right droplet in the air, right? Theoretically, yes, right? Theoretically, yes, right? Theoretically, yes. But even though it is theoretically yes, in the real life, it is not a main problem, right? It is not a main problem in the real life, but theoretically, yes, right? Okay, right, fine. Look here. Fine. The next thing. Other transmissions like contact, right, vertical transmission, right, those are very, very, very rare, right? Those are very, very rare. Okay. Okay, right. Okay. So coming to the clinical presentation, majority are having mild symptoms or they are asymptomatic. Majority are having mild symptoms or they are what? Asymptomatic. They are asymptomatic. The second thing, right? So about 10 to 15% are having severe symptoms. The rest 5% are having critical illness, right? So they can have sepsis, septic shock, multi-organ failure, ARDS, and death. Okay, fine. So if you look at the symptoms, I told you the incubation period is about 5 to 6 days, right? So symptom onset to development of severe disease is roughly about 1 week. I told you roughly about day 6, day 7 only, they will come with a shortness of breath. So symptom onset to death is about 2 to 8 weeks. If you look at the recovery, as I said, when it comes to mild disease, right? So the recovery soon is about 2 weeks, but it can be long, about 3 to 6 weeks when it comes to severe disease, right? So if you look at the infectivity, right? Okay, so majority of the people, the infectivity is very much reduced by about 7 days, right? By about 7 days. but in severe disease people, it can be prolonged, right? Okay, fine. So if you look at the lung complication, acute lung injury, ARDS, etc., acute lung injury, ARDS, etc., right? Okay, so those are the main things, right? Those are the main things. Fine, guys. The next thing, right? So if you look at the risk factors, right? Okay, if you look at the risk factors for severe disease, right? Old age, male sex. We talk a lot about diabetes, guys. We talk a lot about diabetes, but remember, hypertension is also like that, right? Hypertension is a well-known risk factor. We are seeing more and more patients with hypertension getting there, right? So cardiovascular disease, COPD, diabetes, right? Obesity, malignancy, those are the other risk factors. Clear? Okay. I told you, Rama, look at me, the next important point, right? Okay. I told you guys, okay, now the people who are getting bad, right? Who are getting bad, right? So somewhere around day 8, day 9, day 10, they are having a high inflammatory response. Yes or no? Right? Day 8, day 9, day 10, they are having high inflammatory response. Yes or no? Right? So what is the reason for that? What is the word we used? Come on. Cytokine, right? Storm, right? Cytokine storm, cytokine storm. So it's very important, right? Okay, to detect these people before, right? It's very important to detect these people before. So how to suspect this is people who are having high fever, right? People who are having dyspnea on admission, right? There is a scoring system called Q-SOFA for sepsis, right? I have discussed in the paper class. I will discuss in the paper class, right? Q-SOFA in sepsis, right? So if you look at the investigations, if the neutrophils are high, if the lymphocytes are low, lymphopenia, especially when the lymphocytes are less than 700, 800, right? When the lymphocyte count is less than 700, 800. If the people is having high lactate dehydrogenase, LDH, if the CRP is high, if the ferritin is high, if the interleukin 6 levels are high, right? If the ACE2 levels are high, if the D dimers are high, these are the markers of, right? These are the markers of high inflammatory response, right? High inflammatory response. That's why we check the ferritin. That's why we check the LDH. That's why we check the D dimers, right? So these are going up, tells you the patient is going into the hyperinflammatory phase. In other words, this patient is going into the cytokine storm, right? Okay. Are you okay up to this point? Yes or no? Come on, guys.
Yes,
huh?
Yes, sir.
Right, look here. Now I told you one of the markers which tells you the patient is going into the cytokine storm is what? Hyperinflammatory, CRP. Remember, CRP can go itself, right? CRP can go itself, right? Just by a COVID pneumonia per se, right? COVID per se will increase the CRP, right? COVID per se can increase the CRP, right? COVID per se can increase the CRP. Understood? Right? Now, listen to me. The basics are very important, right? That's what I'm telling all the time, right? That's what I'm telling you. Even I emphasize a lot in my Viva class also, right? It's the basics, guys, right? At the end of the day, what matters is the basics. If your basics are good, you will manage anyway, right? So that's why we put a lot of emphasis, right? When it comes to neurology and all the classes, cardiovascular, whatever it is, right? The basics, your platform is important. Now, what is our basic knowledge, right? If the CRP is high, normally what is your worry? Huh? I mean, what we study in medicine? Forget about the COVID. COVID is new, no? Huh? Infection, no? Right? Infection, isn't it? Infection. Right? Infection. So, look at me, right? Look at me. Now, in a COVID patient, we say day 8, right? Day 8, patient is hypoxic. Patient is hypoxic. CRP high, right? CRP high. What are the two possibilities? Tell me, what are the possibilities? Whether there is a cytokine storm, hyperinflammatory phase. Whether there is a cytokine storm. What is the other possibility? Come on. Whether this is a secondary bacterial infection. Secondary bacterial infection. Neutrophils will be high in both. Neutrophils will be high in both. Right? CRP is going to be high in both. CRP is going to be high in both. Now, look here. Right? It's available in the national hospital as well as in the private sector. One of the things we are doing is procalcitonin. Right? Procalcitonin. It's a blood test. Right? Procalcitonin. It's a blood test. Right? Procalcitonin. Right? Procalcitonin. Right? Procalcitonin will be high if there is a secondary bacterial infection. Right? Procalcitonin will be high if there is a secondary bacterial infection. Right? Procalcitonin will be high if there is a secondary bacterial infection. Right? Secondary bacterial infection. Okay. Fine. That's the way to differentiate. Right? Right. Okay. Because it's very important, guys. Why? Why? Why it's important? Common sense. As I always tell, 50% of the medicine is common sense, rest is nonsense. Yeah. Why it's important? Your treatment changes. Excellent. Your treatment changes. Because if it is a hyperinflammatory state, you have to give what? Immunosuppression. Right? Your steroids or whatever it is, you have to give immunosuppression. Just imagine you misdiagnose this as you misdiagnose an infection, and if you give immunosuppression, right? What will happen in such a case? Huh?
Infection will worse.
Yeah, it will worse. Infection will worse, right? That's why it's important. Right? That's why it's important. Okay. Now look here. Right. Got it, guys? Yes, no? Right? Just a few words about this infection. Right? Features, investigation. So in the COVID, right, they have lymphopenia, right? If the lymphocytes are less than 700, is actually bad. Right? CRP is increased, ferritin is increased, LDH is increased. They can have high D dimers. If the procalcitonin is increased, that tells you this is a possible bacterial sepsis, right? So they can have myocardial infarction, they can have heart failure, they can have myocarditis. There you do the troponin, BNP, proBNP, right, to see the cardiac involvement, right? So it can affect the liver. You check your AST, you check your ALT, right? Okay. So you do the chest X-ray, etc., right? Again, the same thing what I said is there in a graph, right? Okay, right. Let me look here. So this is a few words about the radiology, guys. Radiology. So the radiological changes, most of the time when there is a possibility, we are doing a HRCT. What is HRCT? High resolution CT. Whenever there's a possibility, we are doing an HRCT. So the other changes are mainly in the peripheries, just next to the pleura. So initially they are having ground glass. This is what you call as ground glass, guys. You can see these changes, what you see here. Like these are the ground glass appearance, what you get in the HRCT in the initial COVID pneumonia, right? So in the initial stage, this is what you get here in the COVID pneumonia. These are the ground glass appearance, right? Later, when it progresses, like there are some fibrotic bands in between, right? They develop some fibrotic bands in between, right? So this is what we call as a crazy paving. It's called crazy paving, right? So later at the peak, when there is an infection at the peak, right? When there is a secondary infection, you're having full-blown consolidation, right? It's like your pneumonia is a full-blown pneumonia, right? if your time is bad, they can develop lung fibrosis, right? When the infection resolves, they can develop lung fibrosis, right? So whenever there is a suspicion, they are going to develop lung fibrosis. Sometimes at this point, we are giving methylprednisolone to stop this, right? We are giving methylprednisolone to stop this, right? Right, okay, this is a long-term sequence, right? So that's why sometimes people after discharge, like I got about 7-8 calls from my students, like parents, relations, so they have been discharged 5 days back, 10 days back, like still they are dyspneic. Right? Got it? Clear, guys? So right. So these are the few things I told you, right? Okay, right. So these are mild, moderate, and severe disease, right? So some of the people we come across the COVID, they are only test positive, right? You go and do a test to do something else, right? So your test is becoming as positive, right? So those are asymptomatic people, right? Then the other people, they are in mild disease, right? But they do not have shortness of breath. They are not dyspneic, and the chest X-ray is normal, but they have some cough, they are having arthalgia, myalgia, fever, loss of smell, etc. Right? Those are symptomatic mild disease, right? Then the moderate disease, right? So they are having pneumonia, guys. They are having pneumonia, they have fever, cough, dyspneic, they are dyspneic. The respiratory rate can go up to about 30, right? The lungs can have crabs, but the saturation is less than 94%, right? But they do not have features of severe pneumonia, right? What is severe pneumonia? I'll tell you, right? They do not have that severe pneumonia features. Those are called moderate disease. Then the severe disease. What is severe disease, right? Either your saturation is less than 90% when you are on maximum oxygen supplement, right? Or else, right, saturation is 94% with oxygen, but they are having some other features, like other features such as respiratory rate is more than 30. They are using the accessory muscles, the sternocleidomastoids, right? Right, intercostal muscles of respiration, right? Your X-ray is showing more than 50% of the lung involvement, right? Your PaO2 to FiO2 is less than 300. So they are hemodynamically unstable. Those are severe disease. Clear? Are you okay up to this point? Come on, guys. Yes? Okay, look here. Before going to management, actually, one point which I have not included in my slides is just the 2 words about this rapid antigen test and the PCR, right? Right, and the PCR. Look here, guys. You might have heard about the word this rapid antigen test, yes or no, right? So if you look at this rapid antigen test, right? Rapid antigen test, right? Rapid antigen test, right? Rapid antigen test, right? Rapid antigen test. So if you look at this rapid antigen test, right? If it is positive, right? It's usually positive in the 5 to 7 days, right? It's usually positive in the first 5 to 7 days. It can be positive, right? If it is positive, it's positive, no issues, right? If it is positive, it's positive. You have the disease or you have the infection, right? But if it is negative, right, that does not mean, right? Okay, you don't have the disease, right? Because there can be false negative. There can be false negative, right? There can be false negative. Okay, so that's why sometimes even if it is negative, right? Even if it is negative, right? Even if it is negative, if you have a high degree of suspicion, right? If you have a high degree of suspicion, even in negative cases, when there is a high degree of suspicion, right? We are doing the PCR, right? PCR, right? This PCR test, right? Right? What we are calling is called the NAAT. What is NAAT is? Nucleic acid amplification test, right? Nucleic acid amplification test, right? NAT, nucleic acid amplification test, right? Clear? NAT. So the common NAT, right? The commonly this is done with the RT-PCR, right? Right? Reverse transcriptase PCR, right? Commonly it is done with the RT-PCR, reverse transcriptase PCR, right? Reverse transcriptase PCR, right? Okay. Lamai, look here, it's very important. So usually when you are doing a PCR, you are taking a nasopharyngeal as well as a oropharyngeal swab, right? You take a nasopharyngeal as well as oropharyngeal swab, right? Nasopharyngeal as well as oropharyngeal swab. Nasopharyngeal as well as oropharyngeal swab. Have you heard a word called CT value? Right? Have you heard about a word called CT value? Come on. Yes or no? Huh?
Yes.
Yes. What is CT value is? This is called cycle threshold. Cycle threshold. It is called cycle threshold. Right? Cycle threshold. Cycle threshold. Right? It is called cycle threshold. Right? Cycle threshold. Look here, guys. If the CT value is low, you are more infective, or if the CT value is high, you are more infective.
CT value is not more effective, sir.
If the CT value is low, you are more infective. Right? If the CT value is low, you are more infective. Now, look at me. If the CT value is low, you are more effective. If the CT value is about 30, 32, you are less effective, almost non-effective. Right? If the CT value is about 30, 32, you are less effective, almost non-effective. Okay. What is the reason is, guys? What is this CT value? Cycle threshold is how many times you have to amplify, how many cycles you have to amplify the specimen before your viral RNA becomes detectable. How many times you have to amplify the specimen before the viral RNA becomes detectable, right? How many times you have to amplify the specimen before the viral RNA becomes detectable, right? Right? Okay. So if the CT value is 5 means after 5 times amplification, your RNA is detectable. After 5 times amplification, your RNA becomes detectable, right? If the CT value is 30 means after amplifying 30 times only your RNA is becoming detectable. Understood, guys? Yes or no? So that's why less value is bad. Less value means your RNA is easily detectable, right? Less value means your RNA is easily detectable. Yes or no? Come on. Yeah?
Yes, sir.
Right. Fine, look here. Fine. Now the management. Right? Now the management. So what are we going to do in asymptomatic people? Right? You do a risk assessment. If this patient is a high-risk patient, you monitor the vital parameters, heart rate, respiratory, saturation, temperature, right? So at least twice a day, depending on the risk. If the patient is a high-risk fellow, you will, right, check more, right? Okay, you continue the regular medication, you continue the regular medication, etc. Okay. Right. So the symptomatic people with a mild infection, right? So you monitor the baseline symptoms irrespective of the risk factors. But if they are high risk people, you monitor frequent. You do a full blood count and CRP. It's very important, guys. We should, just because the COVID is very common, we should not tell everything as COVID, right? Everything as COVID, because you are aware the dengue, right? Dengue and what you say, lepto also can be, right? Lepto also can be, right? So you closely monitor the progression, right? You give the paracetamol for pain relief, etc. Right? Okay. Right? Now look here. People with a moderately severe disease. So they are having COVID pneumonia, right? With a saturation less than 94%. Saturation less than 94%. But they do not have the features of severe pneumonia. I have already discussed the severe pneumonia now, right? What are the features of severe pneumonia? So they do not have the features of severe pneumonia, right? But the saturation is less than 94%. You have to closely monitor for the progression. You monitor the heart rate, respiratory rate, saturation, forward, right? And the blood pressure and temperature as indicated, right? So here, when the saturation is less than 94%, right, we have to give them oxygen. We have to give them oxygen, right? How to give oxygen, I'll come back to this. There are various ways to give oxygen, such as nasal prongs, face masks, venturi mask, non-rebreathing masks, etc. Right? So when there's another method called self-proning. You turn the patient position, right? These leaflets are pasted in the hospital. So that we ask the patient to change their position frequently, because this is one of the mechanisms to increase the ventilation, right? Right, ventilation. So because we want to, right, manage the ventilation perfusion mismatch, right? We want to, right, this is what we are doing, right? Okay, look here, guys. Actually, right, one of the important things when it comes to this is, right? Okay, one of the important things when it comes to this is oxygen, right? Oxygen. Okay, oxygen. My first point to you guys, right? In a way, today's session is good, because if the today's session is not there, right? I don't think I will be talking to you about oxygen in any other place in medicine, because it's not really indicated in medicine syllabus. You don't have to know in medicine, right? In a way, I think it's good in some other ways, that some good things from COVID, right? Okay. Now, you may be aware, guys, right? You may be aware. There are various ways to give oxygen, isn't it? There are various ways to give oxygen. So one of the way, right, to give oxygen is the nasal prongs, right? Nasal prongs, right? Nasal prongs. You have seen this, right? Say you have seen this, right? These nasal prongs, right? Right, nasal prongs. Then there are face marks, venturi marks, non-rebreathing marks, etc. Look here, right? If you look at the ways to give oxygen, some of, right, my first point to you is, remember, oxygen is a drug. Clear? Oxygen is a drug, right? So we have to use this cautiously and efficiently, right? That's why we are having a shortage of oxygen, right? So if you look at these oxygen delivery devices, right, there are two types of devices. One is called low pressure, low flow oxygen devices, right? One is called low pressure, low flow oxygen devices. So if you look at their performance is variable, right? Variable. It's not 100%. You can't tell, like, this is, right, 100% efficient. You can't tell like that, right? Their performance is variable, right? Variable, right? These are low pressure, low flow oxygen devices. So what are the devices which is falling under these categories? Nasal cannula, your nasal prongs, face masks, venturi mask, non-rebreathing mask. These come under these low flow, low pressure devices. Then we are having another set of devices, high pressure, high flow delivery devices, right? So the important thing here is, one of the very important thing is high flow nasal cannula, right? High flow nasal cannula, right? Your CPAP machine, continuous positive airway pressure machine, right? And the ventilators, right? These are high flow devices, right? These are high flow devices. Clear? I just want to tell a few words, guys, right? Okay. Now, if you look at the nasal cannula, like maximum you can give only about 40% of the oxygen, right? So maximum delivery you can give is 6 liters per minute, right? You can use this in the less severe pneumonias, right? Okay. So maximum you can go up to 4 liters per minute, right? Which is roughly about 40% of the oxygen, 36% of the oxygen, right? Okay. So when you are keeping the flow rate about 1 liters per minute, right, it is delivering only 24% of the oxygen. When you increase the flow rate, right, when you increase the flow rate to 2 liters per minute, it increases to 28%. 4 liters is giving about 36% of oxygen. My message to you is, tomorrow, right, when you become house officers, right, there is no point in giving 15 liters to the nasal cannula. You got it? Right? There's no point in giving 15 liters to the nasal cannula, because maximum it can go up to 4 liters. Right? Okay, because it's a wastage of oxygen. Right? It's a wastage of oxygen. Right? 4 liters, 6 liters is 4 liters roughly. Clear? So the next one, if you look at the face mask, guys, face mask, right? So here you can go up to 50% of the oxygen, 50% oxygen you can use, right? So here, right? So you can go up to 10 liters per minute, right? Face masks, right? 10 liters per minute. So if you look at the venturi mask, right? So you may be aware of this venturi mask, right? Okay, venturi mask, you may have heard about this, right? Okay, guys, right? Venturi mask, right? So there is a color code, right? Right? So the 24% venturi masks are blue color masks, right? 40% masks are orange color masks, 60% masks are green color masks, 35% ones are these yellowish color masks. Okay, there is a color code, right? So this blue color mask can give about 2 to 4 liters per minute, which can deliver about 24% oxygen, right? White one, it delivers about 4 to 6 liters per minute, where you will be able to deliver about 28% oxygen, right? The orange one can deliver 40% oxygen at 10 to 12 liters per minute. The maximum you can go with a venturi is 60%. Clear, guys, right? So tomorrow, when you, it may not be asked in the exam, but right, so 326 students who are going for internship tomorrow, you should have some idea about these guys, right? So you can't go and give 100% oxygen with a venturi. Got it? Right? So that's why, right, from your aim, right, you want to pass the exam, that's your aim, right? From my point of view as a teacher, right, so there are two things. One is you should pass the exam. Second, you should be competent and confident, right? So I think I will pay a lot of attention to that also. That's why the reasons, the courses and those things are becoming more and more strict, right? While the current trend is to become more and more lenient, I will make the course more and more strict, because now there's no need to bother about the numbers now, guys. Like almost 90%, no 95% is there in the class, right? So anyway, they will come. If you have to pass, you have to come, as simple as that, right? So the training will be more and more strict, and because it's your parents' money. You are spending your parents' money here, right? So so we also have to give a good service, right? So so get these concepts, right? So no point in giving increasing the flow. You can't increase more than this, right? So you can't give a more than 60% with a, what do you say, venturi. So if your patient is unable to, listen to me, right? Don't worry about writing. Its presentation is there. tomorrow, if your patient is unable to maintain the saturation with a green color Venturi, 15 liters flow, you have to go to the next device. You got it? Right? Right? That's the maximum you can do with a Venturi. Do you understand what I'm talking? Yes or no? Right? So tomorrow, if your patient is unable to maintain the saturation with a green color Venturi, right? That is your 60% when you are giving it 50 liters per minute, still the saturation is low. Now, no point. You have to go to the next. What is the next? Non-rebreathing mask. Right? What is the next? Non-rebreathing mask. So when it comes to non-rebreathing mask, Ramai, look at me. Right? When you are giving 15 liters per minute flow rate with a non-rebreathing mask, that can approximately give about 85% oxygen. Right? You are giving a 85% oxygen with a non-rebreathing mask. What is the oxygen in the normal air? What is the oxygen in the normal air? You can't study arts and commerce and come and sit here, right? That is to sing some songs and study some religion. What is the normal oxygen? 21%, no? 21%, right? Right? Here the right NRBM, non-rebreathing mask, will give up to 85% oxygen. Clear? Right? So if you can't maintain the saturation with that also, you have to go for the high flow. Right? You have to go for the high flow. Right? High flow. Right? So the important thing about the high flow is also not, it's very expensive, guys. This high flow nasal cannula. So this high flow nasal cannula is a high flow device. This is the device which can give 100% oxygen. Right? This is the device which can give 100% oxygen. You can go up to 60 liters per minute. Right? So where you can give 100% oxygen. Right? Okay. Ramai, do you understand what I'm talking? Yes or no? Right? So the next option is you have to go for what? Right? Non-invasive ventilation and invasive ventilation. Got it? Right? Kids, are you okay? Right? So in other words, what I am telling is, guys, if you can't maintain with one device, right? If you are unable to maintain the saturation with one device, you go to the next device, then the next device. So it's called escalation. Right? It's called what? Escalation. Clear? Yes or no? Yeah? Right. Now, the next point. So when a patient is stable in one device, right? Say with a Venturi 60%, he is stable. Right? With a Venturi 60%, he is okay. Right? So his oxygen demand is going low. So you reduce it. Right? You reduce it. Right? You reduce it. It's called de-escalation. Right? It's called what? De-escalation. Understood, guys? Yes or no? Right? So you escalate. When we are okay, you bring it down. You de-escalate. Right? You de-escalate. Yes or no? Come on. Right. Right. Okay, good. Sorry, guys. Okay, guys. Yeah. Fine. Okay. Now I come to the individual drugs. Right. So in a patient whose saturation is less than 94%, in other words, when the patient requires oxygen, right? Requires oxygen. This is the place we are using steroids. Clear? This is the place we are using steroids because in patients who need oxygen, who require oxygen supplementation, steroids are having a mortality benefit. In other words, it reduces the death, right? So there are many trials, right? So including the famous trial called recovery trial, which tells steroids are beneficial in these patients. Clear? what is the steroid we are using? Dexamethasone. Dexamethasone. We are using 6 milligram, right? Either IV or sometimes oral, right? We continue it for 10 days, right? We continue it for what? 10 days. Clear? 10 days, right? So remember, we are using dexamethasone when they require oxygen. We don't use it before that. No benefit in patients who do not require respiratory support, because I told you, right, if you go and use this early, it can prolong the what? Huh? Viremia. Viremia. So the next question, some of you might ask me, so when it comes to steroid, is it only dexamethasone, right? Can't we use prednisolone? Can't we use, like, hydrocortisone? Hydrocortisone. Like, feeling tired, guys, early days. I can do even 10 hours class at a stretch. You know, I have done 10 hours in Russia, in 12 hours I have done at a stretch in Russia. But anyway, their climate is good though, right? But even 2 hours is seem tiring. Maybe that's a problem of restreaming, right? Yeah, natural ability goes down, deconditioned, right? Come on, look here. Okay, look here. So if they do not require oxygen, no benefit, right? So you can use oral prednisone or hydrocortisone, but having said that, best is dexamethasone, right? Best is dexamethasone. Clear? Right? So only when you can't use dexamethasone, you are using this. Right? Now, in people with a moderate pneumonia, the other important thing we are giving is enoxaparin. Enoxaparin, because I told you COVID is a prothrombotic state, right? So the drug of choice is enoxaparin. We are starting from the prophylactic dose, right? 40 milligram daily, right? 40 milligram daily, right? You may remember from the medicine knowledge, I hope you still remember, right? We had to reduce the dose of enoxaparin in people with the renal failure. So there we are reducing the dose, right? Reduce. Otherwise, we are giving, right, 40 milligrams subcutaneous enoxaparin, right? Right. Whenever you start giving oxygen, you give enoxaparin. Sometimes even before that, you can give enoxaparin, right? Even before that, you can give enoxaparin. No harm, no, right? So especially we are giving in the moderate disease, right? When the saturation is at 94%, you give enoxaparin. You don't have to know much, right? Sometimes looking at the patient, right, we increase the dose if the D dimers are going up, right? If the, let me look at me. If the D dimers are going up, right? If the oxygen demand is going up, if the patient is getting bad, we increase the dose of enoxaparin to twice daily dose, because our worry is whether the patient is developing pulmonary emboli, right? Right, where the patient is developing pulmonary emboli. Inhalers you can continue, right? Where the patient is developing pulmonary emboli, right? Because it's a prothrombotic conditions, right? It's a prothrombotic condition, right? So, well, antibiotics. When are you going to give antibiotic? Right? Only when you are suspecting a secondary infection, right? Only when you are suspecting a secondary infection. When will you suspect a secondary infection? Ongoing fever. CRP is high, right? Neutrophils are high. Neutrophils are high. But remember, all those can occur in COVID per se, right? COVID itself can cause all those. Like COVID itself can cause all those. So whenever there is a doubt, what will you check? What do you check? Huh? Procalcitonin. Whenever there is a doubt, you will check the procalcitonin, right? Procalcitonin. So you give something like a ceftriaxone, right? You will also consider atypical coverage like clarithromycin. Okay, right. Fine. People, the drug, whatever Trump got, right? Right, okay. He talked a lot about this now. The fellow was right, guys. Like looking back and thinking about Trump, like just to recall that man, right? I think we should be thankful to him because of him only we are having this many vaccines, right? Because he bypassed the normal system and he like in the fast track he approved the vaccine, right? So whatever he said, right, everything was right now, no, right? So those days, right, you were jogging, taking jog. Anyway, I respect him, right? So we miss him desperately, and we miss him desperately in Afghan as well, right? Okay, look here. So this is a drug he got by remdesivir, right? Nice videos, right? So look here. Well, coming to this drug, nowadays we talk a lot about this in Sri Lanka also, right? Okay. So in people who require oxygen therapy, this is found to reduce their mortality, right? So, but who are the people, COVID pneumonia, who require supplemental oxygen? When the kidney functions are okay, GFR is more than 30. The liver enzymes are not high. They are less than 5 times of the normal limit. So in these people, when they come early, there is a use of this remdesivir, right? Remdesivir, clear? Right. Just a few words about, right, severe pneumonia, guys. Severe pneumonia, right? Severe pneumonia. So what is the severe pneumonia? As I told you earlier, if the saturation is less than 90%, that itself tells you this is severe pneumonia, right? If the saturation is less than 94%, but you have some evidence of deterioration, right, as assessed by the following criteria, that is respiratory rate is more than 30, right, radiographic infiltrates are more than 50% involvement, PaO2 is to FiO2 less than 300, right? So hemodynamically unstable, these people again falls under this severe pneumonia, right? So the options are, you are giving high flow oxygen, high flow nasal oxygen. I told you, right, here you can achieve 100% right oxygen, you can give it, right? So if they are not responding to that, you will go for the other invasive things like the CPAP, right, NIV, and then you go to the right invasive ventilation, right, with the right prone positioning, etc. You don't have to know about this, but you are not going to manage this. Clear? Right. So this is the same thing I told you guys, right, about the saturation, etc. Like how we are going up with the maskers, like how we are coming down with oxygen. And here I just want to tell you one point, guys. Look here. Like just to show you the magnitude of the problem. Now I look here. Now, right, we all say no, where there is a shortage for oxygen, right, etc., etc. Right, I want you to understand this is not easy, guys. Like this is not an easy thing, because just imagine, like even when you are giving a low flow rate, 5 liters per minute, right? 5 liters per minute oxygen. I just want you to understand the problem. You are needing 300 liters per day. Yes or no? Yeah, 5 liters per minute, 300 liters per hour. 300 liters per hour. 7,200 liters per day, right? So you need 6 watt cylinders per day for one patient. People who are on high flow oxygen, right? So when you are giving 10 liters, 600 liters per hour, right? So you need 12 watt cylinders per day, right? You may have seen the large cylinders, not the normal cylinders, but you are using the word, the large cylinders, like the jumbo cylinders, right? So when you are going to the 60 liters, guys, look, imagine 60 liters, like you need 12 jumbo cylinders per day for one patient, right? So now you can see the demand, right? You can see the demand, right? Right? Things are not that easy, right? Especially for us, it's not very easy, right? Right. So in people with a severe pneumonia, right? Okay. So when the D dimers are high, I told you we increase the enoxaparin dose, right? You go for the twice a day dose, therapeutic dose, right? Okay. Fine. Before going to the next drug, tocilizumab, right? Right. Okay. Look here. Just I'll give you 1 minute. Just see whether are you okay up to this point. Okay. Oh, good. People, right? The exam batch, don't worry. Yeah, I will start the paper class in around 15th or 20th. There, we know what is good for you rather than you, right? The right decision will be taken at the right time, right? So juniors, just the session 3 starting on tomorrow, join, and after that I'll restream the section wise as well if possible quickly. I will do it mostly, and but make sure you complete the theory before coming to the section wise and final papers. That's very important. September 15th or 20th will be ideal. We can slowly go, right? So I think tender loving care, we'll do about maybe only 8 classes are paid. There'll be another 7, 8, 9 classes free. A lot of papers are there, guys, and a lot of time is there, no? Aim high. Shall we do? Okay, look here. Now, that drug, tocilizumab. So a lot of people asking also, is tocilizumab is available? So is it available in the black market? Can you buy somewhere? Right? People are panicking about this tocilizumab. Right? Okay, look here. What is tocilizumab? I told you in the COVID, when there is a hyperinflammatory phase, there we are having a cytokine storm. Yes or no? Right? So one of the main antibody there is a interleukin 6, IL6. So what is this tocilizumab is a interleukin 6 blocker. Interleukin 6 blocker. Right? So sometimes you can check the interleukin 6 levels before giving tocilizumab. Right? Okay. So this interleukin 6 plays a major role when it comes to the cytokine storms. Clear? When it comes to tocilizumab, guys, okay, right? Okay, we are not giving tocilizumab to everybody. We are not giving, right? Because one of the problem is, right? Once you give tocilizumab, it will bring down here, what do you say, CRP to very low level, undetectable. Your CRP will become undetectable. Clear? So what is the problem there? You can't detect the infections, right? You can't detect the infections by CRP because tocilizumab will bring down the CRP to very low level, right? The second risk of tocilizumab is infection. They can develop other infections. So we can't use it to everybody. Clear? So who we are, right, using tocilizumab is people with a hypoxemia with a high flow oxygen, high flow nostril oxygen, with a right 40% oxygen, 40% oxygen. Either they are currently on steroids or already steroids is given. CRP more than 75. Now I look here. CRP more than 75. Look at me. Why we are doing CRP here? Huh? Huh? To detect the what? Yeah, paper class 15th or 20th of this month. Yeah. Why we are doing CRP here? To detect the hyperimmune response. To detect the hyperimmune response. Right? To detect the hyperimmune response. What is the worry? What is the worry? CRP can be high in hyperimmune response. It can be high in where? Infection. Right? So you do CRP, you want the CRP to be above 75 to say this is a hyperimmune response. At the same time, right? At the same time, you want to make sure this is not what? This is not what? Infection. So you also do what? Procalcitonin. You also do what? Procalcitonin. You also do procalcitonin. Right? You also do procalcitonin. Clear? You also do procalcitonin. Clear? Fine. Right? So you make sure the procalcitonin is normal. So in addition to the inclusion criteria, they should have additional 2 here. Right? Either D dimers are more than 1000, ferritin is more than 700, LDH is more than 300. Right? So you have to exclude the secondary infection before this. Right? You don't have to know the dose. We are giving 8 milligram per kilogram dose. Right? So you can give a second dose after 12 hours depending on the response. It's a multidisciplinary team management. right? Okay, right. So these are the contraindications if there is active TB, herpes zoster, sepsis, if there is a gastrointestinal perforation, if the ALT is more than 5 times, if the platelet is less than 50,000, if there is a severe neutropenia, right, you can't give. So these are the other supportive cares, fluid management in COVID, fluid management, treat the infection, treat the renal impairment, seizures, control the sugar. Very important, guys, nutrition, right? Nutrition, right? So all these patients, we are giving vitamin C, vitamin C. All these patients, we are giving vitamin D, vitamin D, vitamin D, right? Vitamin D, right? Just a few words about discharge, right? Discharge. Okay, before coming to discharge, I'll talk a few words about the clinical challenges we are facing, right? Right. So one of the problem is this hypoxemia, right? And you have to give oxygen, you have to titrate the oxygen, you have to escalate the oxygen. When they are okay, you have to de-escalate the oxygen. So that is one problem, right? Because there's a diffuse alveolar damage, right? There's a severe pneumonitis. The second problem, as I told you, just to summarize what I have discussed up to this point, right? Right, just to summarize the problems I have discussed up to this point. The second problem what we have discussed is, right, hyperimmune response, that is the cytokine storm, right? So this is the one we are tackling with immunosuppression. This is the one we are tackling with the steroids, right? Tocilizumab, etc. Clear? So the next problem I have already told you is the thromboembolic problem, pulmonary embolism, myocardial infarction, heart attacks, right? Renal failure, strokes, etc. So then the next thing I told you, right, it's a vicious cycle, right? It itself causing a vicious cycle. So they can have patient can have self-inflicted lung injuries called PCL, right? It's called PCL, right? They can also have ventilator-associated lung injuries, VILI, right? VILI. So this pulmonary embolism can cause pulmonary hypertension. You can have a secondary infection with a bacterial infection, fungal infection. You may have heard the word mucormycosis, black fungus, right? There was a lot of media attention on that, right? So I told you later they can develop organizing pneumonia, right? That can lead to lung fibrosis. So whenever you think, you don't have to know this, right? It's beyond your level. Whenever they think they are going into organizing pneumonia, whenever we think these people is going to develop the lung fibrosis, right? So that's the time they use methylprednisolone injections, right? Injections, okay? So. Okay, guys. Right, look here. So discharge, right? So when you are discharging the patient from the ICU to the ward, right? Okay, ICU to the ward, right? Right, you have to continue the right enoxaparin, right, until the patient is going home, right? Going home, right? The people who are on therapeutic anticoagulation, right? So enoxaparin twice a day, therapeutic dose, right? So they need, right, oral anticoagulant, warfarin on discharge, right? Okay, fine. So now we'll move on to the post-COVID, right? Are you okay? Can I move on to this? Just 1 second, just have a look. Have you had class on COVID earlier? Or is the first class? Don't know. Right? Clear, look here. Usually, guys, look here, from the time of onset of symptoms, okay, right? No need, home quarantine, no need, okay? Right, the symptoms can go up to 4 weeks, 4 to 4 weeks, right? So sometimes what you call this as long COVID is when you have something like some symptoms left, which is going beyond 4 weeks, right? Which is what you call as a long COVID. And it's about, 1/3 of the people, right, who develop this COVID, right, they are having this, right? So if you look at these, they are fatty, right? The quality of life is going down. Their muscles are weak, myalgia, muscle weakness, joint pain. They have some dyspnea, I told you, because there can be lung fibrosis, right? Some of them even are like they need some oxygen for a long time, right? They're anxious, depressed, right? These people are actually, I remember, right, another good, right, doctor, like Dr. Aminta Fernando, Dr. Afra Sadikin used to tell us all the time, right, right, he said, again, they are doing a very good job at National Hospital, right? I think all what I learned or what I'm doing here is what I learned from them, by just by listening to them. So he used to tell even the patients after discharge, they come with the sleep disturbances, they come at night, right? They say they are waking up at night, sleep disturbances, right? Post-traumatic stress disorders, right? But your brain is lagging, right? Cognitive disturbance, right? So if possible, just before the exam, right? If there's a possibility of you can be, right, keep out of COVID, try to be, right, safe, right? Headaches, because there is sometimes long COVID, like memory, there can be some issues, right? But that's not the reason for failure though, right? Palpitations, right? Chest pains, right? Thromboembolism. Sometimes they can go into chronic kidney disease, right? Like glomerulonephritis and chronic kidney disease, right, etc. Right? Fine. Look here. Sorry. Yeah. So these are the long-term sequences I told you, right? Right. They can have organizing pneumonia, right? Pulmonary vein from, like pulmonary embolism, thrombosis, etc. So blood, right? They can have thromboembolism, like heart. There can be palpitation, chest pain, right? So myocardial infarction, arrhythmias. Like, it's a very important thing, guys. Actually, I read about this because my mother had it, some tachycardia. So that's the reason I just read about this. It's autonomic dysfunction, right? The tachycardia after COVID, palpitation after COVID. This autonomic dysfunction is very well described after COVID, right? So when it comes to renal, right, okay, you're having acute kidney injury sometimes. Sometimes you can go into CKD, it's called COVAN, right, okay, coronavirus associated nephropathy, right, COVAN, right, it's a long-term problem, right, of the renal impairment with this. So neuropsychiatrics, right, myalgia, headache, autonomia, cognitive impairment, etc. Endocrine problems, GI problems, right, skin problems, and you may have heard about this because I'm leaving this, let the pediatricians talk about this, right? By multi-system inflammatory syndrome, MICC, right? So it's not our area though, it's mainly seen in the pediatric population, even though the diagnostic criteria says it is less than 21 years, right? They're having fever, elevated inflammatory markers. It's like your MODS, right? Multi-organ dysfunction syndrome, right? With COVID infection, right? So, right, it's a classically the children about 7 years, right? So we see here also, but it was initially described in the African and Afro-Caribbean, but we see now more and more here as well, I think, right? They can have the coronary aneurysms like here, right? And neurological things like Kawasaki-like coronary aneurysms, neurological things, etc. Right? So again, a slide to show you the extra pulmonary involvement of COVID, right? Right, neurological involvement is there, renal involvement is there, liver, elevated aminotransferases, elevated bilirubin, right? Then it comes to a GI, nausea, vomiting, diarrhea, loss of appetite, abdominal pain, lot of skin things, right? Lot of skin things, right? Petechiae, right? Libido reticularis, urticaria, vesicles, etc. Right? Your sugar can shoot up. They can have hyperglycemia, right? So, right, you have to control with the insulin, diabetic ketoacidosis, right? In the heart, they can have cardiomyopathies, right? There's something called Takotsubo. What is Takotsubo? It's a stress-induced cardiomyopathy. You don't have to know much, right? It's a stress-induced cardiomyopathy. And my students who are joined here, who are doing the postgraduate, you have to know this guy, Takotsubo, right? Those who are doing the MDs, right? You have to know this. Right, myocardial injury, right, cardiac arrhythmias, cardiogenic shock, right, right, pulmonary, etc., etc., etc. Right. So discharge criteria, right? So the asymptomatic, now you can be at home. You don't have to bother, this is the old one anyway. So earlier they said 10 days from the first positive test, PCR or antigen, right? So if the PCR CT value is more than 30, you don't have to be isolated, right? Right now, little bit changes are there, you can be at home, right? So in mild to moderate disease, at least 10 days from the time of symptom onset, right? At least 24 hours, right? From without fever, and without paracetamol, right? When the symptoms have improved, right? And your oxygen, right? So one of the things is you check the oxygen with the exertion. You ask the patient to squat 10 times, right? So that's what you check. You ask the patient to squat 10 times, right? And you see whether there is any desaturation. When they are not desaturating, then discharge, right? So severe symptoms, like depends, guys, either 10 days from the symptom onset or 20 days, right? And again, 24 hours without fever and Panadol, right? And when the symptoms have improved, right? Cough, shortness of breath have improved, right? So with the exertion, there is no significant desaturation. You ask the patient to sit up, get up, sit up, get up 10 times, squatting, and you see there is a desaturation, right? So when the patient is clinically fit, you can discharge, right? So we don't do a PCR on discharge normally. We don't do, there is no exit PCR, but sometimes it is done in immunocompromised people, right? Because they can keep the infection going on and can infect the others. So in immunocompromised people, sometimes on day 14, you do a PCR. Otherwise, we don't do the PCR on discharge. Clear? You don't have to know the trials. That is not for you, right? You don't have to know this. I'll come to the last part. Tocilizumab I discussed. Guys, look here. Well, now a lot of questions. Why a lot of people are asking this again and again. Right, sir, what about ivermectin? Right, can we use ivermectin? Right, right. Okay, guys. People, sometimes I misses your messages, right? So, I try to message, right?
Before starting ivermectin, I would like to know whether if antibody index is more than like if antibodies are present and PCR was done after 14 days, but still the CT value is less than 30, can we discharge the patient?
So if the CT value is less than 30, there is a risk, right? There is a risk, right? Okay. So, but if there are no clear-cut consensus there, it's better if you can discharge when the CT value is above 30, right? Right. So basically, when the CT value is above 30, definitely your antibodies will be more than 10, right? The antibodies will be more than 10, right?
So the situation is such that the patients who are in the ICC centers, who are like meeting the new patients who are coming to the centers, like when they are about to be discharged, like they're getting exposed to the new viral load. When we repeat the PCR test on patient request, like we see the patients are having CT values like not getting beyond 30.
Yeah, actually, yeah, what you say was true. Actually, this problem, like you, we also come across every day, right? We also come across every day. Because sometimes you have the antibodies more than 10, but your CT values is actually theoretically there is a risk, right? Theoretically. So in case if you discharge, you get to give them the proper, what do you say, proper advice, right? Telling to isolate them, right? Telling to isolate them, right? So especially this problem is coming now because of this delta, right? Am I right, Arindu? Right? CT values are very low rather than the old days, right?
Yes, sir. Yes.
Yeah, that's the thing. So there is a small risk is there though, right? Right. So sometimes you are pressed with beds, you have to send them, but a small risk is there. So where is the presentation, right? It's there in a Telegram group, right? Somehow you find the link and join, right? Yes, shared several times, up to you know, right? Right. Okay. So ivermectin, right? So a lot of questions I'm getting about this ivermectin. People, I used to reply all the messages sometimes, right? If I miss it, right, I'll send again. I'll try to send again but don't send me guys messages, right? Maybe my far away relative like that, right? Because I'm getting hundreds of messages every day, right? So just something close to you, your right, you about you health condition send, right, but neighbors, right, don't send like that, the headache, right? Coming to this ivermectin, right? Well, can we use it? Can we use it? Sri Lankan guidelines still did not include this right now, but almost all are started to use this. They are using this now. No harm, guys, no harm, right? So I will also say, right, that even the chest physicians are using now, right? In the viremia phase, you can use this because, right, there is no harm basically, right? So if you look at the trials, right, so there are trials which are showing it reduces the hospital admission, it reduces the mortality also, right? So some people are, criticizing these trials, but having said that, there is nothing bad about ivermectin, right? Okay. So in the viremic phase, if you want to use, right, if there's a possibility, if you want to use, you use, right? So, right, okay. The next thing. Don't have to know this, right? Well, a quick thing about these vaccine, right? Okay. Have you all vaccinated? Huh? Under medical student category, you can get the vaccine, right? Yeah. Right. That is one good thing you all got. Yeah. Right. Yeah. Better get vaccinated, eh? Right. I think there's no contraindication to vaccine at all. Right. So you may be aware of these AstraZeneca, like our COVID shield, right? Which you need 2 doses. It's basically using a genetically modified virus. It's a viral vector. The storage is about 2 to 8 degrees. The other 2, the American ones, this Moderna and Pfizer, like these 2 are RNA vaccines, right? These 2 are RNA vaccines, right? The main problem with the Pfizer is the temperature, like -80 to -60, and the Moderna is 25 to -50, right? The Sputnik is again using a viral vector. The Chinese ones, the Sinovac and Sinovac, right? Sinovac and Sinopharm. So both of these are using the inactivated viruses, weakened viruses, right? And the storage is 2 to 8 degrees C, right? If you look at this Johnson & Johnson, right, the Johnson product, right, this Johnson & Johnson, it again uses a viral vector, right? Again, the temperature is not an issue here, right? So that's about the vaccine types, right? Effectiveness, guys, right, it varies, from time to time, right? So, right, the studies are showing various things. Again, right, okay. So at the preliminary point, right, so the Pfizer was found to be about 95%, right? Moderna is about 95%, AstraZeneca is about 70%, right, after 2 doses, right? Sputnik, we don't know, only you, the Russian students may be aware, right, 92%, right? So Sinopharm is about, again, 80%, right? Sinovac is about 50%, right? But these changes, day to day, these effectiveness changes day to day. There is a new study, I think, to me, I think AstraZeneca looks good, right? The COVID shield or AstraZeneca looks good. I think it seems to be a good vaccine, right? Sometimes even better than Pfizer in some studies, right? Okay. So, yeah, right. So that's it, and that's all about COVID, right? Yeah. I think you may have some classes earlier, but I think I try to give everything you have to know about COVID. Yes, it's enough, I hope. Yeah. What do you think? Yeah, guys, what do you think? Anything you want to ask? So that's it. So all the best, guys, right? It's after a long time, so live class. So see you then. Bye.
Sir, what about getting a Pfizer booster following AstraZeneca?
Anything is better, bro. Huh? Anything is better, right? If you get the chance, you get it, right? Okay.
So can we cocktail the vaccines? Like first get the AstraZeneca, after 1 or 2 months, get the Pfizer or something?
There are no clear-cut evidence, but I have seen some of the comments by immunologists also, right? Microbiology knowledge and immunology knowledge says no harm, isn't it? There's no harm, right? It's anyway going to protect, right? I also don't find there's anything wrong with that. Right, yes, okay then.
Thank you, sir.
Okay.
Thank you, sir.
Okay. Okay, guys. Okay. Can you tell about the paper class? I will start on 15th or 20th. There, the paper class part 2. Part 1 is already done. The restreaming is going on. Those who want, right, can join or contact me.